From the different data that have been presented for nusinersen or for gene therapy, we understood that um, earlier is better, and so newborn screening makes perfect sense. Newborn screening programs have started all over the world, in Australia, in Taiwan, in a maternity of Moscow, in two regions of Germany, two regions of Italy, in southern Belgium, and in 31 states in the US. And probably there are new pilots that are starting in several other countries. If we want to see things in a positive way, it means that it increases. If we want to see things on a more negative way, it means that today it's about 2 or 3% of the European population who is actually screened for spinal muscular atrophy. So it means that we still let 97% of European babies at risk to be detected just by the symptoms. The question that you can ask for newborn screening is it cost effective? Do we save money? Because it's great to see our patients doing better, but do we save money? And this is an open question. On one hand, you can say, well, to screen a baby is about €3 per baby, right? And if you have to screen 10,000 baby to get a single one, it means that you have to spend €30,000 to catch a baby with spinal muscular atrophy. But if you can avoid a wheelchair, if you can avoid non-invasive ventilation, it's very likely that actually you save money by just starting the treatment some weeks earlier and paying these €30,000 to capture these patients. But it's very likely also that you will treat more patients because, unfortunately, if we do not screen, we see sometimes patients in the clinics with a very severe disability. And when they come to the consultation, we have to discuss palliative care rather than treatment with patients because we are too late. So it's very likely that if you think in terms of budget impact, screening at birth will conduct to treat more patients. We presented our preliminary study of our preliminary data of a study that we are conducting in southern Belgium, and where we compare patients who have not been treated from the natural history study, patients who have been treated after the symptoms, and patients who have been treated before the symptoms. And in these three populations, we collect prospectively the medical care, how much time they get hospitalized, how much treatments they are on, how many times they have to see a doctor. So, and also, what are the consequences for the family? Are the parents working? Are they able to keep their job? So that's all the questions, not only of the medical cost, but also of the societal cost of spinal muscular atrophy. So that what we present, it's very preliminary data, but it shows that indeed these patients who are treated before the symptoms are consuming much less hospitalizations and medication than patients who are treated after the symptoms. Then come the questions of the carriers, because you could say, well, if we could identify in the population the carriers, for instance, by offering the opportunity for carrier screening, then we could probably suppress the disease. This is not entirely true because, as you might imagine, there may be new mutations, and you have also illegitimate pregnancy, and you have all the people who will never go to a pre-conceptional consultations and will have a baby without asking the permission to the doctor, and that's so far so good. But there is another reason why carrier screening failed to detect some cases, and there was a poster that shows that actually there's a certain proportion of the population in which the alleles in which the SMN1 genes are on the same allele, which means that if you have two copies of your SMN1 gene, but they are on the same allele, on the other allele, you don't have a SMN1 copy. And because of that, you can, in a carrier screening program, say, well, this person has two alleles of SMN1, there is no risk. But the problem is that these two alleles are on the bad one. The two genes are on the same allele, and if the baby receives the allele without the SMN1 gene, then it can be affected. What does it mean? It means that carrier screening and newborn screening should not be put in opposition. They should be used together to allow to decrease the incidence of the disease in the population and to be sure that the cases that we cannot avoid are properly identified and treated before the symptoms to get the maximal benefit of the treatment.